Tracy Leduc. I am a YSC advocate here at the San Antonio Breast Cancer Symposium, and I'm going to let you know a little bit about what's going on here today. Right now, I'm talking to Dr. Holly Niravath from Baylor, and yesterday she did a presentation on endocrine therapy. Is the price of forever too high? And so we're going to see what thoughts she has on that. You started with yesterday talking a little bit about the text trial and the soft trial that both looked at ovarian suppression and then the use of either tamoxifen or an aromatase inhibitor with those. Kind of in a nutshell, can you tell me what the results were from those two trials?
Absolutely, yes. So there was a combined analysis of soft and text, which were two separate trials. They both looked at premenopausal women who needed adjuvant endocrine therapy, so meaning women who had ER-positive breast cancer. Half of them, the two trials were slightly different, but the combined analysis looked at women who had received ovarian suppression plus AI therapy versus those who had received ovarian suppression plus tamoxifen. And then later, the larger analysis came out, which compared those groups to women who received tamoxifen alone. And we found that overall, women who received ovarian suppression plus an endocrine therapy did better than the ones who had tamoxifen alone. The absolute difference was about a little bit under 8% in terms of breast cancer recurrence. So the improvement is there, but it's very small. And the main question is who we should be offering this endocrine therapy to, because the benefits are so small. So when we say that only less than 8% of women benefit, that means obviously the vast majority of women may not benefit. And the issue is that with medicines that are so toxic, like ovarian suppression, where women go through symptoms of premature menopause, so for example, hot flashes, vaginal dryness, joint pains, depression, insomnia, all of these are very common side effects. We want to try to understand better how we can narrow down that group of ER-positive women to understand who's going to truly benefit from the ovarian suppression, the more aggressive therapy. And the talk yesterday was kind of discussing how we can try to identify those groups a little bit better. And we know that the women who are extremely young, so usually less than 35, they're the ones who are the most likely to actually recover menstrual function after chemotherapy because they have a higher, what we call ovarian reserve, meaning the ovaries still have a lot of oomph left in them. So even after they have chemotherapy, those ovaries can recover and start making estrogen again. Unfortunately, that estrogen may be feeding the tumor in many cases. So these young women benefit from the ovarian suppression because we're actually preventing those ovaries from waking up again. Whereas women who are a little bit older, let's say older than 45 years old, they may have been premenopausal going into the chemotherapy, but if they're permanently postmenopausal coming out of the chemotherapy, then obviously they won't benefit as much from ovarian suppression because the chemotherapy has effectively suppressed their ovaries. And we also know that women who are higher risk in general, so meaning those who have positive lymph nodes and more aggressive types of cancer, larger cancers, these are the ones that probably do benefit from the more aggressive therapy. Whereas women who are fortunate enough to have very low risk, small ER-positive tumors may not be the ones that we should be offering these toxic therapies to.
You've mentioned a couple of times that they're toxic, and I think most cancer patients understand toxicity, but what are some of the specific side effects or toxicities that you see with ovarian suppression and an AI?
So the most common one that happened when we looked at the combined soft and text analysis in the arms where everyone was getting ovarian suppression, more than 90% of women were getting hot flashes. And about 35% of those women got it to the point where it significantly affected their daily life and it was becoming a major concern for them. So hot flashes is a significant issue when the estrogen level drops so suddenly, as it does with ovarian suppression. The other thing that was very common is arthralgia. So about roughly 3/4 of women had joint pain while they're on this medicine, which kind of the way that people describe it to me is that they suddenly feel like an older lady, meaning that they're stiff when they have to get up from a seated position or getting out of bed. It takes a little while to get going. We also see a lot of vaginal dryness and sexual dysfunction because if you have vaginal dryness, typically intercourse is very painful. So we find a large problem with that as well.
Are those things that get better the longer someone is on the medication, or is it something that kind of, when you first start on it, it gets bad and that's how bad it's going to be?
Yeah, So unfortunately, it improves only very, very minimally. So there was an analysis of these same patients on soft text where they followed them over 5 years for these types of side effects, and we saw that the hot flashes remained largely the same with only very small improvement. The same thing with the vaginal dryness. Actually, the vaginal dryness over 5 years got worse than when they first started. And the one thing that did improve slightly was the joint pains. So over time, those joint pains can get a little bit better, but they still don't get back to the baseline of where women started from before we ever started them on the ovarian suppression.
So when a young woman is at a point where she would be needing to make a decision about endocrine therapy, what questions do you think are the most important for that young woman to ask her doctor about the pros and cons of ovarian suppression and an AI versus tamoxifen?
Right. So I think here there's probably two very important points that patients should consider when they're talking to their doctors about this. So number one is to try to talk to your doctor about understanding the risk that you have as an individual. So meaning, what is your risk of recurrence based on the type of breast cancer that you have, the age at which you had it, the extent of it, meaning the stage of breast cancer, because that will really help determine which treatment may be appropriate for you. It's largely determined by your risk, where the low-risk people don't need as aggressive therapy. And then the second thing is to really talk to your doctor specifically about the side effects of each of these options. Tamoxifen versus ovarian suppression plus tamoxifen versus ovarian suppression plus an aromatase inhibitor. Because ultimately, the medicine is only going to be effective if you're able to take it and continue it for the entire time. Another thing that we found in these studies is that compliance was actually quite poor. Up to about 1 in 5 women stop taking these medicines because they're so toxic. So I think talking to your doctor and trying to understand the differences between the side effect profile for each medicine and what you as an individual can actually tolerate is very important from the outset. Because we see it sometimes where women start these medicines and they become so disillusioned with the side effects that they're not even necessarily always willing to try a different one and see if it works better. So trying to know which one is right for you from the beginning is important.
Great. Well, thank you so much. The talk yesterday was very good, and you've given us a good synopsis of what younger women need to know about this area.
Great.
So,
thank you so much.